Welcome to the deep dive. When we normally think about the major organs that run our lives, we usually picture the brain or the heart, maybe the lungs.
Right, the big ones.
Yeah, exactly. But today, we are going to explore a tiny, like a 3.5 to 4 centimeter stretch of the human body that honestly dictates a massive amount of your daily comfort.
Oh, absolutely.
I am talking about the anal canal.
It's a remarkably small footprint for something that, well, when it malfunctions, it can completely hijack a person's life.
Always.
The sheer density of the engineering packed into those few centimeters is it's extraordinary.
And really, that is the mission of today's deep dive.
Yeah.
We are going to decode the complex clinical anatomy of this area.
Which is much needed, honestly.
Right. We want to demystify some incredibly common yet, widely misunderstood issues for you, like hemorrhoids, fissures, and fistulas.
Yeah, the things nobody wants to talk about at dinner parties.
Exactly. But most importantly, we want to extract the medical rationale behind exactly how and why they are treated the way they are.
Right.
Okay, let's unpack this. Because for you, the listener, well, while this topic might make some people a bit squeamish, understanding the mechanical engineering of your own body is the ultimate shortcut to being well-informed.
Yeah, it really is.
It's how you advocate for your own health.
Absolutely. And, to understand the pathology, to really grasp why these structures fail, we have to look at the blueprint first.
Right, the basic anatomy.
Yeah, and the clinical sources actually emphasize that this canal is measured in two distinct ways, which, frankly, often causes confusion.
Oh, really? 2 ways?
Yeah. So there is the anatomical length, which is about 3.5 to 4 centimeters long.
Yeah.
But surgeons, well, they operate based on the surgical length.
Which is different, I assume.
Right. It's
Yeah.
slightly shorter. It's just 2.5 centimeters. That measurement basically starts from the puborectalis muscle sling all the way down to the anal verge, where the true skin begins.
Okay, so the surgical length matters because it really defines the functional zone.
Ex-
So if you were to, travel down this canal from the inside out, you would pass a highly specific set of landmarks.
A very busy set of landmarks, yeah.
Right. You start at the anorectal ring at the top,
Yeah.
and then moving down, you hit the columns of Morgagni, which are these vertical folds of mucosal tissue.
Yeah, and between those folds are little pockets. We call them anal crypts or sinuses.
Right, and right at the bottom of those are the anal valves.
Exactly. And below those valves, you hit the pectinate line, which is also known as the dentate line.
Okay, dentate line. Got it.
Yeah, and continuing downward, you enter this transitional zone called the pectin, which eventually meets Hilton's white line.
Hilton's white line. That sounds so formal.
It does. But it's actually a palpable groove that marks the lower edge of the internal sphincter. And finally, you reach the anal verge.
Okay, but before we get to why that pectinate line in the middle is the most critical landmark in the entire region, we really need to talk about the security system wrapping around this whole canal.
Oh, the sphincters? Yes.
Yeah. The sources use the mnemonic ICE to remember the 3 concentric layers of muscle. ICE, internal conjoint and external.
It's a great way to remember it. So in ICE, the internal anal sphincter, it operates entirely outside of human consciousness.
Thank goodness for that.
Right. It is a thickened continuation of the smooth muscle from the rectum, meaning it is totally involuntary.
Okay.
And this specific muscle provides 70 to 85% of your resting anal tone.
Wow, that much.
Yeah, it works around the clock
Yeah.
while you are sleeping, while you are walking. It maintains a constant state of contraction to ensure continence without you having to dedicate a single thought to it.
Yeah, we certainly don't want to consciously manage that 24/7.
No, absolutely not.
So the conjoint longitudinal muscle sits in the middle, and then you have the E, the external anal sphincter.
Right.
And that one is striated muscle, meaning it is actually under your voluntary control. It's the physical muscle you actively squeeze.
Exactly, yeah.
And it works in tandem with that puborectalis sling we mentioned, which it creates an 80-degree anatomical bend that physically kinks the canal shut.
It's a brilliant mechanical design. Continence relies on this highly delicate combination of that angle, the resting sphincter tone, sensory feedback, and rectal compliance.
It's basically an engineering marvel.
What's fascinating here is that the structural muscle is only half the story.
Really?
Yeah. The true complexity actually lies in the microscopic lining itself, specifically at that pectinate line we mentioned earlier.
Oh, right, the dentate line.
Right. This line represents a massive developmental divide. During human embryological development, the top half of this canal grows downward from the hindgut.
Which is endoderm tissue, right?
Exactly. And the bottom half grows upward from the outside, which is ectoderm tissue. They basically crash into each other and fuse right at this microscopic boundary.
It is like a tense international border where suddenly the language, the currency, and the laws completely change.
That is a perfect way to put it.
If you cross this microscopic line, your body's wiring just switches.
It really does. Medical students actually map this sudden shift using the mnemonic every supply changes at pectinate.
Okay, wait, walk me through that one.
Sure. So the embryology changes from endoderm to ectoderm. The vasculature completely shifts its origin. The epithelium changes from columnar mucosa above to squamous epithelium below.
Right.
The returning veins drain into entirely different systems. The yelping pain describes the nerve shift. And crucially, the cancer type changes depending on what side of the line you are on.
Okay, let's drill into those last two because they honestly dictate almost everything about the patient experience.
They absolutely do.
Above the line, the area is innervated by the autonomic nervous system, so it does not feel sharp somatic pain.
Right, it's mostly just pressure or stretch.
But below the line, it is innervated by the somatic nervous system, specifically the pudendal nerve,
Yeah.
making it like highly sensitive to pain, touch, and temperature.
Very sensitive, yes.
And the cancer difference is just as stark, isn't it?
It really is. Tumors forming above the line originate from glandular tissue, so they present as adenocarcinomas.
Yeah.
But tumors below the line originate from the skin-like lining, presenting as squamous cell carcinomas.
Wow.
Yeah, the treatment protocols, the surgical approaches, and the chemotherapy regimens are entirely different based entirely on which side of that embryological border the tumor originates.
That is wild. And, this invisible border completely dictates the presentation of our first major clinical issue today, which is hemorrhoids.
Ah, yes, hemorrhoids.
Right around this pectinate line, we have clusters of vascular tissue. And we really need to clarify something right away because the general public almost universally misunderstands this.
They really do.
Hemorrhoids are normal anatomy. Literally everyone has them.
Exactly. The fundamental reality is that they are cushions of submucosal vascular tissue. They're basically designed to act as a watertight seal for the anal canal.
Right, they are not varicose veins.
No, not at all. And they naturally sit at 3 specific anatomical positions. The 3 o'clock, 7 o'clock, and 11 o'clock positions, well, if the patient is viewed in the lithotomy position.
Okay, so if they are normal, when is it actually a problem?
We only use the term hemorrhoidal disease when these structural cushions engorge, prolapse, or become symptomatic.
Got it. And whether they act up above or below our international border determines the symptoms.
Precisely.
Internal hemorrhoids sit above the pectinate line. Because of the autonomic nerves, they don't cause pain. Their defining symptom is like bright red bleeding that might drip into the bowl.
Right, but external hemorrhoids are below the line, so they are covered in that highly sensitive squamous epithelium.
The somatic zone.
Exactly. So if a blood clot forms inside an external hemorrhoid, which we call a thrombosed external hemorrhoid, it stretches that sensitive skin, causing just agonizing pain.
Ouch. So what actually triggers these cushions to swell up and fail?
Well, the mechanical triggers are rooted in anything that increases venous pressure in the pelvis. So chronic constipation, straining during defecation, pregnancy, obesity, and low-fiber diets.
All the classic suspects.
Yeah. They all force excess blood into these cushions, which stretches the connective tissue that anchors them to the sphincter muscle.
Okay, so for the internal hemorrhoids, clinicians use the Golier classification to grade the mechanical failure from 1 to 4.
Right, the Golier scale.
Grade 1 simply bleeds. Grade 2 prolapses, meaning the tissue physically pushes out of the canal when you strain, but the elasticity of the tissue pulls it back in spontaneously.
Yeah, it snaps back on its own.
But grade 3 prolapses and requires the patient to, manually push it back inside. And grade 4 is just permanently incarcerated outside the canal.
Exactly. And the intervention always scales with the mechanical severity.
Well, makes sense.
First-line therapy is entirely conservative. High-fiber diets, aggressive fluid intake, and warm sitz baths to relax the underlying sphincter tone.
But what if that doesn't work?
Well, if a grade 2 hemorrhoid continues to prolapse or bleed, the gold standard office procedure is rubber band ligation, or RBL.
How does that work?
The physician deploys a really tight rubber band directly at the base of the vascular cushion.
Right. And because the band is placed above the pectinate line, up in the autonomic zone, the patient feels pressure but no sharp pain.
Exactly. The band just chokes off the blood supply and the tissue necroses and sloughs off a few days later. It creates a scar that fixes the remaining tissue back to the underlying muscle.
But wait, I have to stop and push back on this.
Sure, go ahead.
If we just establish that these cushions are normal, functional anatomy providing a watertight seal, why is the instinct to tie them off with rubber bands or, cut them out surgically in the severe grade 3 or 4 cases?
That's a fair question.
Aren't we stripping the body of its own functional machinery?
Well, the goal is never to completely eradicate the anatomical structure. Surgical hemorrhoidectomies, like the widely used Milligan-Morgan technique, they are designed to excise only the redundant, prolapsed, or severely bleeding tissue.
Ah, okay.
Yeah, we leave bridges of healthy mucosa intact. We are pruning the overgrown branches to restore the seal, not, cutting down the tree.
That makes a lot more sense.
Because if a surgeon were to aggressively remove all the hemorrhoidal tissue circumferentially, which was the basis of this historical operation known as Whitehead's procedure, the anatomical consequences are disastrous.
Yeah, the sources mentioned that leads to something called an atropian.
Right. Whitehead's deformity, or
Yes.
extropion. It occurs when the surgeon removes so much tissue that they actually have to pull the inner columnar lining of the rectum all the way down and sew it to the outside skin.
Oh, that sounds terrible.
It is. Because rectal mucosa constantly secretes mucus, the patient suffers from permanent, uncontrollable wetness and severe compromises to their continence.
So Whitehead's procedure is basically a massive red flag.
Oh, it is strictly avoided in modern surgery, specifically to preserve the functional anatomy.
So what does this all mean?
Well, basically.
It means if you are experiencing painless, bright red blood, you are likely dealing with an internal hemorrhoid that might just need more dietary fiber or a simple banding procedure.
Exactly.
But if you experience sudden, severe pain, you're dealing with a completely different mechanical failure, which leads us to our next pathology.
Yeah.
The anal fissure.
Right. If uncomplicated internal hemorrhoids bleed without pain, a fissure is characterized by severe tearing pain.
Tearing pain, yeah.
Pain that can last for hours after defecation, and it's frequently accompanied by a small amount of bright red blood on the tissue.
The sources define a fissure as a linear tear in the anoderm, strictly distal to the pectinate line.
Right, below the border.
That places it squarely in the somatic, highly sensitive pain-feeling zone. But what is truly bizarre to me is that a massive 90% of these tears occur in one specific anatomical spot.
The posterior midline.
Exactly, the very back of the canal. Why is that specific spot so prone to tearing?
It comes down to a mechanical vulnerability caused by the vascular anatomy. So the blood vessels supplying the anal canal, the inferior rectal arteries, they enter from the lateral sides.
Okay, from the sides.
Yeah, and by the time their terminal branches wrap all the way around to reach the posterior midline, the vessels are microscopic and they fail to overlap or anastomose well.
Oh, I see.
So this creates what we call a watershed area, a zone of naturally poor blood perfusion.
I think of the pathophysiology of a fissure like a self-sabotaging cramp.
Oh, I like that analogy.
Right, because you pass a hard stool, and the mechanical trauma causes a superficial tear in that posterior midline.
Yep.
Because it is below the pectinate line, the somatic nerves trigger intense pain. And that pain causes the involuntary internal sphincter to reflexively spasm. It just clamps down.
But it clamps down hard.
But because the muscle is clamped, it physically compresses those tiny blood vessels struggling to deliver blood to the watershed area.
Exactly, so the tissue becomes ischemic.
Right. And without blood flow, the tear cannot heal. So the open wound causes more pain, triggering more spasm, choking off more blood. It is just an endless self-sustaining feedback loop.
And if that ischemic loop persists for more than 6 weeks, the acute tear morphs into a chronic fissure.
Which changes things physically, right?
It does. The body's constant failed attempts to heal the area create a distinct triad of chronic signs.
The chronic triad.
Yeah. The chronic inflammation causes lymphatic drainage to back up, creating a swollen skin tag at the bottom of the tear known as a sentinel pile.
Okay.
At the top of the tear, you find a hypertrophied anal papilla. And the ulcer itself becomes so deep that you can visually see the circular white fibers of the spasming internal sphincter exposed right at the base of the wound.
Wow, so you can actually see the muscle. To break the loop, you obviously have to break the spasm.
Precisely.
If the root problem is muscle hypertonia cutting off blood supply, the treatment must focus on chemically or physically relaxing that specific muscle.
Right. Conservative management focuses on softening the stool to prevent further trauma. but the medical interventions target the muscle directly.
Like with ointments, right?
Yeah,
Mhm.
we utilize topical chemical relaxants like GTN glycerol trinitrate or diltiazem ointments. These agents force the smooth muscle of the internal sphincter to relax, dropping the resting pressure and allowing oxygen-rich blood to finally reach the watershed area.
To finally heal the ulcer.
Hmm?
And, you listening to this have to appreciate the systemic interconnectedness of the human body here.
It's pretty wild.
GTN is a potent vasodilator. You apply this ointment locally to heal a tiny tear in the anal canal, but the medication absorbs directly into the systemic bloodstream
It does, yeah.
because it dilates blood vessels everywhere. Roughly 50% of patients experience a pounding, debilitating headache. You apply medicine to the anal canal, and your head physically throbs.
It's true. The systemic absorption is a significant barrier to compliance, which is why clinicians often pivot to topical diltiazem or physically injecting botulinum toxin into the internal sphincter.
Botox.
Yeah, Botox. It chemically paralyzes the spasm for a few months. But when medical management fails, the gold standard surgical intervention is a lateral internal sphincterotomy, or LIS.
What does that involve?
The surgeon makes a precise, controlled incision to physically divide a portion of the internal sphincter muscle, which permanently releases that resting pressure.
Okay, but the sources attach a massive clinical warning label to the LIS procedure.
They absolutely do, and for good reason.
You are physically cutting a muscle that maintains continence. There's an inherent risk of minor incontinence to flatus or liquid stool, particularly in older patients or women with a history of obstetric trauma.
Right.
And the absolute non-negotiable rule is you never perform an LIS on a patient with Crohn's disease.
Never. Because Crohn's disease inherently causes chronic diarrhea and ongoing inflammatory tissue destruction.
It's a recipe for a disaster.
It is. If a surgeon intentionally cuts the internal sphincter of a Crohn's patient, they are crippling the precise muscle needed to hold back liquid stool. They're practically guaranteeing permanent incontinence.
So what do they do for those high-risk patients?
In high-risk patients, surgeons utilize an advancement flap. They essentially mobilize a patch of healthy mucosal tissue to drag down and cover the fissure like a biological Band-Aid, completely bypassing the need to cut any muscle.
Brilliant. Okay, so we've covered surface tears. But the clinical sources highlight an entirely different class of pathology when things go wrong deep inside the tissue.
Yeah, this is where it gets more complicated.
We mentioned earlier that there are tiny anal crypts and anal glands situated right at the pectinate line.
Right, so the anal glands secrete mucus to basically lubricate the passage of stool.
Makes sense.
Their ducts open into the anal crypts at the pectinate line, but the physical body of the gland burrows outward. It penetrates through the internal sphincter muscle and rests in the intersphincteric space right between the two muscle layers.
Okay, so they're kind of buried in there.
Exactly. And if one of those microscopic ducts gets blocked by fecal debris or bacteria, the gland becomes infected.
And it doesn't just form a surface pimple, right?
No, the infection is trapped deep inside the tissue architecture. 90% of anorectal abscesses and fistulas originate from these blocked glands. The medical term is cryptoglandular infection.
Cryptoglandular. Wow.
Yeah, and as the trapped bacteria multiply, they form an abscess, a walled-off cavity of pus. Because the space is confined, the pus has to go somewhere. It follows the anatomical path of least resistance through the fat and muscle planes.
Like tracking through the anatomy.
Exactly. The medical literature uses the acronym PIIS to categorize where the pus pools. The P stands for perianal, accounting for roughly 60% of cases.
Okay, perianal.
Yeah, that's where the pus tracks downward and presents as a painful red swelling right at the anal verge.
Got it. And the first I is ischiorectal. That's when the infection penetrates horizontally through the external sphincter into the massive fat pads on either side of the canal, creating a very large systemic infection.
Right. And the second I is intersphincteric, where the pus simply travels straight up or down right between the two muscle layers.
And the S is supralevator. The pus tracks vertically upward, pushing high into the pelvic cavity.
Which is incredibly dangerous.
Yeah, because the patient might not exhibit any external swelling, just deep, unrelenting pelvic pain and a high fever.
Exactly. But regardless of the location, the immediate treatment for any anorectal abscess is aggressive, mechanical incision, and drainage.
Wait, I have to push back on the clinical protocol here.
Okay, what's the hang-up?
We are discussing a severe, localized bacterial infection that causes systemic fever.
True.
Why do the clinical guidelines explicitly instruct doctors not to delay drainage for a trial of antibiotics? Shouldn't systemic drugs be the first line of defense against bacteria?
It seems counterintuitive, I know, but the rationale lies in the physical physics of an abscess.
Physics.
Yeah, an abscess is a cavity under extreme hydrostatic pressure, encapsulated by a thick wall of inflammatory tissue. There is zero vascular flow inside that cavity.
Okay, no blood flow.
Right. Because antibiotics require active blood circulation to reach their target, the drugs physically cannot penetrate the abscess wall.
Wow, okay.
You can pump the patient full of intravenous antibiotics, and the pus will just remain completely untouched. The extreme pressure must be mechanically vented.
So you have to cut it open?
The surgeon must incise the skin and evacuate the pus. Antibiotics are really only prescribed adjunctively if the patient has spreading cellulitis, underlying diabetes, immunosuppression, or systemic sepsis.
So the mechanical drainage provides immediate relief. The pressure is just gone.
It is. But this raises an important question, though.
What's that?
What happens to the empty cavity once the pus is evacuated?
Oh, right. It doesn't just vanish.
No, it doesn't. Because in 30 to 50% of all drained abscesses, the tissue fails to heal cleanly. The patient is left with an abnormal epithelialized tunnel connecting the original infected gland inside the canal to the surgical drainage site on the external skin.
And we call that permanent tunnel a fistula in ano.
Exactly.
It is the architectural aftermath of the infection. The tunnel is lined with tough granulation tissue that literally prevents it from collapsing, leading to chronic intermittent drainage of pus or blood.
It's awful for the patient.
And while 90% of fistulas are cryptoglandular, the sources use the mnemonic critics to identify other systemic causes, right?
Yeah, critics. Crohn's disease, radiation therapy, infections like tuberculosis, trauma, iatrogenic surgical causes, carcinoma, and previous surgery.
So how do you fix a tunnel like that?
Well, eradicating a fistula requires the surgeon to map its exact trajectory through the sphincter complex, and they rely on an anatomical guideline called Goodsall's rule.
Goodsall's rule.
Okay.
How does that work?
If you imagine a horizontal line drawn right across the center of the anus, it divides the anatomy into an anterior front half and a posterior back half. Goodsall's rule dictates that if the external skin opening is in the anterior half, the underlying tunnel tracks in a short, straight radial line directly to the internal canal.
A straight line. Okay. But if the external opening is located anywhere in the posterior half, the tunnel defies a straight line.
Right, it curves.
The infection follows the lymphatic pathways, tracking circumferentially to enter the anal canal precisely at the posterior midline.
It is an incredible piece of anatomical predictability.
It really is.
And knowing that pathway dictates the surgical intervention, if the tunnel is superficial-like, a simple, low fistula that doesn't encapsulate a significant portion of the external sphincter muscle, the gold standard is a fistulotomy.
So they just cut it open.
Yeah. The surgeon passes a probe through the tunnel and physically cuts the overlying tissue open, converting the tunnel into an open ditch that basically heals from the bottom up. It boasts a cure rate exceeding 90%.
But if the fistula is complex, meaning the tunnel drives high up into the anatomy, crossing a massive amount of the external sphincter, a fistulotomy is impossible.
Totally impossible.
Because if you slice through that much voluntary muscle, the patient will suffer irreversible incontinence. And again, you absolutely never perform a fistulotomy on a Crohn's patient due to their impaired tissue healing.
Right. So in those complex scenarios, surgeons pivot to sphincter-preserving techniques.
Like what?
The most common is the placement of a seton. A seton is, well, it's a piece of celastic string or surgical vessel loop passed through the fistula tract and tied into a continuous circle.
Like a loop through the tunnel.
Exactly. A loose, draining seton acts as a mechanical wick. It prevents the external skin from healing over, which allows the chronic infection to drain continuously without forming a new abscess.
That makes sense.
And over months, it stimulates controlled fibrosis, essentially scarring the tract into a tough, fibrous cord. In Crohn's patients, we maintain the loose seton while administering aggressive biologic medications like infliximab to heal the inflammation systemically.
Wow. And modern surgery is so heavily focused on preserving continence, which has led to brilliant mechanical procedures like the lift and VAAFT.
Oh, they are fantastic.
The lift procedure ligation of intersphincteric fistula tract is just a marvel. The surgeon doesn't cut the external sphincter at all. Instead, they make an incision perfectly between the internal and external muscles, find the tiny tunnel crossing that specific gap, tie it off with sutures on both sides, and cut the middle.
Yeah, it physically disconnects the inside from the outside without damaging the structural muscle.
And VAAFT.
VAFT, video-assisted anal fistula treatment, takes it a step further. We deploy a microscopic fistula scope directly into the tunnel.
Like a tiny camera.
Exactly. The surgeon uses the camera to navigate the tract, mechanically brushing away the infected tissue and using an electrode to burn and seal the tunnel from the inside out.
That's incredible.
The overriding objective across all these innovations is to basically eradicate the infection while meticulously preserving the mechanical function of the sphincters.
Which really brings us full circle today. We started by mapping a strict embryological border, the pectinate line, which divides the numb autonomic tissue from the highly sensitive somatic tissue. We explored how normal vascular cushions transform into prolapsing hemorrhoids, depending on which side of that line they sit.
Yeah.
We analyzed how a tiny tear in a low blood flow zone triggers a self-sabotaging muscle spasm that we call a fissure. And finally, we tracked how blocked glands nestled right on that dividing line can tunnel deep through the muscle planes, creating pressurized abscesses and chronic fistulas.
It is a profoundly dynamic, interdependent mechanical system. Every single structure impacts the function of the others.
For you listening, understanding this somewhat uncomfortable anatomy grants you immense power over your own healthcare.
It really does.
Knowing the vital difference between painless bright red blood, which points to an internal hemorrhoid, and severe tearing pain, which points to a fissure or a thrombosed external hemorrhoid, allows you to be a proactive, informed patient.
You can actually understand the specific machinery your doctor is evaluating.
Right.
And, if we step back and connect this hyper-specific anatomy to the broader trajectory of human evolution, it leaves us with an incredibly profound paradox.
Oh, how so?
Well, human continence relies on this exquisite, delicate mechanical balance. The puborectalis angle, the resting tone of the internal sphincter, the vascular cushions acting as watertight seals.
Right.
This entire system evolved over millions of years for species that squatted to forage and consumed a massive volume of wild, indigestible fiber.
Right. Our evolutionary hardware was built for a completely different environment.
Exactly. We have to ask ourselves, how might our modern lifestyle, sitting on rigid, elevated toilets for prolonged periods with our hips and legs at unnatural right angles, combined with highly processed, low-residue diets, how might this not just be causing the acute temporary pathologies we've discussed today?
Wow, that's a good point.
Are we chronically straining the connective tissue? Are we actually permanently altering the functional mechanics of our evolutionary anatomy over generations? Are we outdesigning the functional limits of our own bodies?
That is a phenomenal question to chew on as we wrap up. We build modern convenience, but our biology is still strictly operating on ancient blueprints.
It really is.
Thank you for joining us on this deep dive into the 3.5 centimeters that control so much of our daily lives. Keep asking questions, stay insanely curious, and we will see you next time.